I have met many women over the years who describe the same exhausting experience. They go from one appointment to another, try treatment after treatment, follow every instruction they are given, and yet the discomfort never truly goes away. The itching remains. The burning continues. Sharp, stinging sensations appear without warning. Even the lightest touch can feel unbearable. For some women, sexual intercourse becomes nearly impossible because of the pain. Inserting a tampon can be extremely uncomfortable. Even everyday contact with clothing or simple movements may trigger unpleasant sensations. If you recognize yourself in this description, there is a possibility that you may be dealing with a condition known as vulvodynia. Today, I want to explain what vulvodynia actually is, how we diagnose it, and most importantly, what approaches may help improve quality of life. Many women have never heard the terms vulvodynia or vestibulodynia before. Yet, it is entirely possible to live with these conditions without knowing their names. Perhaps you have already gone through what feels like an endless series of visits to your gynecologist. Maybe you were told that you probably had a yeast infection. Later, perhaps it was thought to be a bacterial infection. Hormonal causes may have been considered, different creams may have been prescribed, medications may have been tried, and still nothing changes. The discomfort remains exactly where it was. When that happens, it becomes important to consider this particular diagnosis. Throughout my years of clinical practice, I have seen how frustrating and isolating this journey can be. Women's health concerns, especially those involving intimate symptoms, have often remained in the shadows. Many women hesitate to speak openly about these experiences, even with close friends, partners, or healthcare professionals. Because of that silence, countless women continue to suffer without understanding what is happening inside their own bodies. By definition, vulvodynia refers to chronic pain or unpleasant sensations affecting the vulvar area that persist for longer than 3 months, despite the exclusion of other identifiable causes. That last part is extremely important. Before a diagnosis of vulvodynia can be made, other conditions must first be ruled out. These include infections affecting the vulva, such as yeast infections and bacterial infections. Certain inflammatory skin conditions must also be considered. One important example is lichen sclerosus, which can sometimes produce symptoms that resemble vulvodynia. Only when these possibilities have been carefully evaluated and excluded can the diagnosis of vulvodynia truly be established. Research suggests that approximately 5 to 10% of women may be affected by vulvodynia. However, many experts believe the true number is likely higher. The reason is simple. Many women never talk about it. For years, these symptoms were rarely discussed publicly. Even today, embarrassment, shame, or fear of not being taken seriously can prevent women from seeking help. What makes this even more challenging is that the diagnosis itself is sometimes overlooked, even among healthcare professionals, despite the likelihood that many more women are living with this condition. That is why conversations like this matter. The more women understand these symptoms, the more likely they are to recognize when something deserves further evaluation. Unfortunately, many women describe their experience as a long and exhausting odyssey. Years of appointments, repeated examinations, one treatment after another. Because the symptoms often resemble more common conditions, women are frequently treated repeatedly for suspected infections. They may receive antifungal medications, antibiotics, creams, ointments, tablets. Yet despite all of these efforts, the pain persists. At that point, we must begin asking a different question. Could this be something other than an infection? And if the evaluation does not support diagnoses such as lichen sclerosus, then vulvodynia becomes an important possibility to consider. What do these symptoms typically feel like? The classic complaints are remarkably consistent: itching, burning, unpleasant altered sensations, pain. These are the 4 symptoms women most commonly describe. We also distinguish between vulvodynia and a related condition called vestibulodynia. The vulva refers to the external genital area. In women with vulvodynia, discomfort may involve the vulva itself and sometimes extend into nearby regions, including the perineum and even around the anal area. Vestibulodynia is slightly different. The vestibule is a U-shaped area located around the vaginal opening. Some healthcare professionals describe it as the entrance area of the vagina. When pain is concentrated specifically within this U-shaped zone rather than affecting the entire vulvar region, the condition is often referred to as vestibulodynia. Another important aspect that deserves attention is the presence of other health conditions occurring alongside vulvodynia. In medicine, we call these comorbidities. Many women with vulvodynia also experience other chronic conditions. Fibromyalgia is one example. Chronic pain syndromes are another. Some women struggle with irritable bowel syndrome. Others experience chronic pelvic pain. Pelvic floor discomfort or pelvic floor tension can also occur alongside these symptoms. Interestingly, the associations extend beyond gynecology. Clinical observations have shown that neck pain, headaches, jaw joint discomfort, and teeth grinding are also reported more frequently among women living with vulvodynia and vestibulodynia. This connection often surprises patients. At first glance, the jaw and the vulva seem to have nothing in common. Yet the body functions as an integrated whole. Patterns of muscle tension, stress responses, and chronic pain processing can affect multiple areas simultaneously. Understanding these connections does not mean that one symptom automatically causes another. Rather, it reminds us that persistent pain conditions are often more complex than they first appear. And this brings us to one of the most important questions women ask. Why does this happen? How does vulvodynia actually develop? The honest answer is that modern medicine still does not have all the answers. Despite growing awareness, this remains an area where much more research is needed. For many years, women's intimate health concerns received far less scientific attention than they deserved. As a result, there are still important gaps in our understanding. What we do know, however, is beginning to provide valuable clues. One of the most interesting observations supported by both clinical experience and medical research is that many women with vulvodynia have a history of repeated vaginal yeast infections and multiple treatments over the years. Again and again, they describe the same sequence of events. An infection develops, treatment is prescribed, the symptoms improve for a short period of time, then the discomfort returns. Another treatment follows, then another. Eventually, even after the infection itself has resolved, the pain remains. Research indicates that these repeated inflammatory episodes may act as triggers in some women, contributing to the development of a chronic pain condition. It is important to understand what this means. It does not mean that every woman who has had yeast infections will develop vulvodynia. Far from it. However, studies suggest that for certain women, repeated irritation and inflammation may leave the nervous system in a heightened state of sensitivity. The body remembers. The tissues heal, but the pain pathways may continue to send alarm signals long after the original problem has disappeared. Animal studies have offered fascinating insights into this process. In some experiments, researchers induced yeast infections in mice and then treated those infections successfully. Even weeks after the infections had resolved, the animals continued to demonstrate increased pain sensitivity. The infection itself was gone, yet the nervous system still behaved as though danger remained. While animal studies cannot fully explain the human experience, they support the possibility that chronic pain may continue even after the original trigger has been removed. Another area receiving increasing attention involves genetics. At present, this field remains relatively unexplored. We simply do not yet have all the answers. However, researchers suspect that inherited factors may influence why some women develop vulvodynia while others do not. This would not be unusual. Many health conditions involve a combination of environmental influences and genetic susceptibility. Some individuals may simply have nervous systems that respond differently to inflammation, stress, or injury. Unfortunately, because women's intimate health concerns have historically been under-researched and often surrounded by silence, progress in identifying these factors has been slower than it should have been. There is, however, another important piece of this puzzle, and sometimes it is the most difficult one to discuss. Psychosocial influences. As physicians, we have a responsibility to approach this topic with tremendous care and compassion. Talking about stress, emotional health, or difficult life experiences does not mean that the pain is imaginary. It does not mean that the symptoms are all in your head. The pain is real. The suffering is real. The impact on daily life is real. But research indicates that emotional strain and life experiences can influence how the body processes and amplifies pain. Current periods of intense stress may play a role. These stresses can come from many directions: professional pressures, financial difficulties, family responsibilities, relationship challenges. The ongoing expectation to always cope, always perform, always remain strong. Experiences of violence, including sexual violence, are also important to acknowledge. A history of unwanted sexual experiences may affect how the nervous system responds over time. Depression, anxiety disorders, panic disorders, and prolonged emotional burden have all been associated with vulvodynia in some women. This is why taking a thorough medical history is so important. Sometimes these conversations involve sensitive questions. Questions about childhood, questions about adolescence, questions about relationships, questions about whether any traumatic experiences have occurred. These are not asked to judge. They are not asked to assign blame. They are asked because they may help us understand the full picture and identify the support a woman truly needs. Clinical studies have shown that women who have experienced violence are more likely to develop chronic pain syndromes, including vulvodynia. Once again, this does not mean that everyone with these experiences will develop pain, nor does it mean that every woman with vulvodynia has experienced trauma. But it reminds us that the body and mind are deeply connected. Another pattern I observe frequently in clinical practice involves women living under constant pressure, women who carry enormous responsibilities, women who rarely allow themselves to rest, women who feel they must remain in control at all times, women who describe themselves as perfectionists, women who continue functioning no matter how exhausted they become. Very often, these women also carry tension within their muscles. We recognize this easily in other parts of the body: neck stiffness, tension headaches, jaw pain, teeth grinding during sleep. These are familiar examples. But there is another group of muscles that often goes unnoticed: the pelvic floor. The pelvic floor is a network of muscles located at the base of the pelvis. These muscles provide support and play important roles in bladder function, bowel function, sexual activity, and overall pelvic stability. Like any other muscles in the body, they can become tense, they can tighten, they can become painful. And many women with vulvodynia have extremely tight, tender pelvic floor muscles. Patients are often surprised when they hear this. They ask, how could stress affect my vulva? The answer lies in understanding how the body responds to prolonged tension. Most of us know what it feels like to have tight muscles in the neck and shoulders. The discomfort can spread upward into the head. It aches. It throbs. We instinctively massage the area because we know the muscles are tense. A similar process can occur within the pelvic floor. The muscles tighten. The tension contributes to pain. Pain then causes the muscles to tighten even further, and before long, a vicious cycle develops. Pain creates tension. Tension increases pain. The cycle repeats itself over and over again. Breaking this cycle becomes one of the central goals of treatment. Unfortunately, treatment is not always straightforward. Whenever medicine does not fully understand the exact cause of a condition, creating a single, universally effective treatment becomes difficult. Because there is no one proven cause, there is also no single cure that works for everyone. Instead, treatment must be individualized. We look carefully at each woman's symptoms. We consider her history. We identify potential contributing factors. Then we build an approach tailored specifically to her needs. At the present time, there are still no universally accepted treatment guidelines that have been scientifically validated as the definitive standard for vulvodynia. This means that the experience and expertise of the healthcare professional involved can make a tremendous difference. Finding someone familiar with this condition is incredibly important. A thorough evaluation allows for a more thoughtful and targeted approach. Because when you begin looking at the different treatment options available, you quickly realize that they can appear surprisingly varied. That is because vulvodynia itself is not identical from one woman to another. The woman whose symptoms followed repeated yeast infections may benefit from different strategies than the woman whose history includes significant trauma. Someone struggling primarily with pelvic floor tension may require different support than someone whose emotional burden has become overwhelming. No two stories are exactly alike, and that is why treatment often works best when multiple disciplines work together. Rather than focusing only on gynecology, we sometimes involve physiotherapists, psychotherapists, pain specialists, and other healthcare professionals. This approach is called multimodal therapy. It recognizes that women deserve comprehensive care, care that sees the whole person, care that addresses not only the symptoms, but also the unique experiences behind them. When I speak with women living with vulvodynia, one of the first things I encourage them to do is to become curious about their own experiences, rather than fearful of them. Sometimes looking back can reveal important clues. Were there repeated infections in the past? Periods of overwhelming stress, major life events, difficult emotional experiences, changes that seemed small at the time, but may have coincided with the beginning of symptoms. Writing these things down and bringing them to your gynecologist can be surprisingly helpful. Small details that seem unrelated may help create a clearer picture of what is happening. Another practical tool is keeping a pain diary. This does not have to be complicated. Simply note when the symptoms feel better and when they become worse. Do they seem related to stress? Do they fluctuate during different phases of the menstrual cycle? How do symptoms change during penetration? How do they feel during sexual activity? What about during self-stimulation? Are there certain activities, situations, or times of day when the discomfort becomes more noticeable? Over time, these observations can help identify patterns and guide treatment decisions. Many women also notice that certain forms of clothing influence their comfort. When pain, burning, and irritation affect the vulvar area, loose-fitting clothing is often preferable. Loose underwear, soft fabrics, fewer synthetic materials. Reducing friction and irritation may lessen some of the discomfort. These simple adjustments cost very little, yet they can make daily life easier. We also spoke earlier about tension and the body's stress response. Because muscle tightness can contribute to symptoms, practices that promote relaxation may be helpful for some women. Autogenic training, meditation, yoga, breathing exercises. Anything that encourages both the mind and body to release tension. These approaches do not eliminate pain overnight. They are not magical cures, but they may help interrupt the cycle of stress, muscle tightening, and worsening discomfort. And importantly, they require no expensive equipment, no gym membership, and very little additional time. They are small habits that many people can begin incorporating into everyday life. When symptoms become especially intense, some women find relief through cooling. Using a cool pack wrapped in a cotton towel for 10 to 15 minutes may temporarily reduce burning sensations. Afterward, allowing the area to return gradually to its normal temperature before repeating the process can be helpful. Interestingly, not every woman responds the same way. Some women actually feel better with warmth. Warm water from the shower, gentle heat applied externally, a warm bath. If choosing a bath, it is wise to avoid heavily perfumed products, scented additives, and harsh chemicals. Simple baths without fragrances, or perhaps with a small amount of oil, are often preferable. Certain oils may also provide comfort. Some women report improvement when using high-quality olive oil. Others prefer jojoba oil. Almond oil is another option frequently mentioned because it naturally contains vitamin E and may provide soothing support, particularly when dryness contributes to discomfort. A small word of caution is important here. Some oils can weaken latex condoms. Therefore, it is essential to read product instructions carefully and ensure compatibility if condoms are being used. Intimate hygiene is another area where many misconceptions exist. Over the years, women have been encouraged to purchase countless products marketed specifically for intimate care. Perfumed washes, scented cleansing products, special foams. However, in most cases, the vulva requires far less than advertising would suggest. Warm water is usually sufficient. If desired, a very small amount of a gentle oil may be used. A soft cloth. Careful drying afterward, that is often enough. The vulva does not require strongly fragranced products, harsh detergents, or heavily perfumed cleansing solutions. Sometimes, symptoms become concentrated in a very specific area. In those situations, healthcare professionals may consider topical preparations designed to reduce discomfort. Certain formulations contain amitriptyline, a medication more commonly known as an antidepressant. Others contain local anesthetics intended to numb painful areas temporarily. These approaches are not permanent solutions. However, during particularly difficult periods, they may provide valuable short-term relief. Now let us turn to one of the most important aspects of treatment. Whenever I care for women with vulvodynia or vestibulodynia, I strongly encourage evaluation by a physiotherapist who specializes in the pelvic floor. This is not general physiotherapy. It is highly specialized care. As we discussed earlier, many women with these conditions have significant pelvic floor tension. Those muscles may be painful, overactive, and constantly contracted. Learning how to identify and release that tension can be transformative. Targeted pelvic floor physiotherapy aims to address precisely these issues, reducing muscle tightness, improving awareness, restoring flexibility, interrupting the cycle in which pain creates tension and tension creates more pain. Another topic that sometimes causes embarrassment, despite being entirely reasonable, involves the therapeutic use of vibration. Think about how people respond to neck pain. They seek massages. They purchase devices designed to provide vibration and muscle relaxation. No one questions that. Yet when the same principle is discussed in relation to the pelvic floor, people often become uncomfortable. Vibrators are commonly associated only with sexuality. However, they may also serve another purpose. High-frequency vibration can encourage relaxation of pelvic floor muscles, improved blood circulation, softening of muscular tension, and if pleasure is experienced at the same time, increased blood flow may provide additional benefits. For some women, this becomes one useful tool among many. If significant emotional distress, unresolved trauma, or overwhelming psychological burden contributes to the overall picture, psychotherapy should also be considered. There is absolutely no shame in seeking this kind of support. Mental health care is health care. For certain women, oral antidepressant medications may also be discussed as part of treatment for vulvodynia, particularly within the context of chronic pain management. Finally, a few words about diagnosis. A careful medical history remains one of our most valuable tools. Listening matters. Asking questions matters. A thorough examination matters. Tests may be performed to evaluate vaginal secretions and determine whether the normal vaginal environment is present. Bacterial infections and yeast infections should be excluded. Conditions such as lichen sclerosus must also be considered carefully. One simple method sometimes used during evaluation is called the cotton swab test. A standard cotton swab can gently touch different areas of the vulva. This helps identify whether certain locations are especially sensitive. Sometimes the pain is concentrated within the U-shaped vestibular region. Sometimes it involves the area around the clitoris. Occasionally, only a few isolated spots trigger significant discomfort while surrounding tissues remain relatively unaffected. Identifying these patterns may allow treatment to be directed more precisely rather than approaching the entire area in the same way. If there is one message I hope you take away from this discussion, it is this: you are not imagining these symptoms. You are not alone. Persistent vulvar pain is real, and although diagnosis and treatment can sometimes be challenging, there are approaches that may help. You deserve to be heard. You deserve careful evaluation, and you deserve healthcare professionals willing to look beyond the obvious and work alongside you to find the strategies that best support your well-being. If this video has been useful to you, please give it a like, subscribe to the channel, and turn on the notification bell. Help me reach 50,000 subscribers so that more people can receive this information.